put my boots on and lace them up. Hard work, not another day's work. Hard work, hard work.
As Sally mentioned, I'm a clinical psychologist in our weight center, which is an outpatient clinic in the hospital for people who are referred by their primary care physicians for their weight-related issues. And we have a bariatric surgery program, but we also have a behavioral weight loss program in which I do some counseling along with dietitians and exercise physiologists. And my interaction with patients has really informed my research. And so I want to kind of tell you the story of my trial in the context of my patient care work. And it's really what got me interested in depression, which is a big focus of mine in the context of obesity. And Sally, actually, this is the study that she was an exercise physiologist on. And so that's how I got to know her 3 years ago. And so today I'm glad that she can now pronounce my name. So from the clinic to the science and back is what I call it. One thing that, oh, okay, yeah, I don't know why I did that. A big interest of mine is the fact that as a clinical psychologist working in a medical school environment is that psychological disorders often co-occur with medical conditions, and that's always been an interest of mine in my training, is to kind of understand why that is. Why do we see elevated rates of different psychological disorders in conditions like obesity, heart disease, and diabetes, and why does that matter? And the reasons why it does matter is it does tend to predict more severe disease, complications, less quality of life, and at the end of the day, morbidity and mortality. And so understanding how to treat mental illness within the context of physical disorders. And it's often the case that it's a bidirectional relationship in that having a psychological disorder can increase your risk for certain physical illnesses and vice versa. So I find that those relationships very fascinating. I've got so many devices here. I just click every button. The challenge from the research side is that clinical trials research typically focuses very much on a single condition. And so let's take obesity, for example, lots of trials on obesity, and they tend to, the samples that they use in clinical trials have exclusion and inclusion criteria, as you may know. And it's often the case, I've noticed, that they tend to exclude people with different psychological disorders. And so to the extent that you have a lot of comorbidity in terms of psych disorders in people with obesity, yet the clinical trials only reflect people who don't have those challenges, this is where there becomes this gap between research and practice. And one of the things that's important to know, especially in a medical school environment, is that often it is the case that docs and psychologists and other practitioners do not utilize the research well in their practice. And it's not because they're stupid or they don't like research. It's often the case that a lot of research actually does not well represent the patient population. And so they find the research that it's not that relevant. And I have discovered that is very true in a lot of times in the obesity literature. I go and treat my patients and they seem very different. Most of them would not meet the inclusion and exclusion criteria of the clinical trials that I read in the literature. And so there's this gap. And so I want to use those interventions, but then you try to use them and you realize there are complications that come up that the research isn't really informing. And so that's something that I've always been very interested in, is how do we make the research more relevant to people who are actually seeking care? Because you can recruit the most motivated people in the world to do interventions, to show your interventions work so well, but what good is that when it comes down to the real world? So what I discovered in our clinic is that we do have a high rate of certain psychological disorders, and the ones that I've been very interested in are in depression, like I mentioned, but we've also seen high rates of other disorders in our population. And I should say the average body mass index coming through our clinic is about a 40 BMI, so that's kind of well within the obese range. Obesity starts at 30. So we see high rates of depression. We've also seen high rates of attention deficit disorder, not necessarily that it had been diagnosed before, but people come up positive on screeners for that. Anxiety disorders, we also see high rates of obesity in people who have psychotic disorders. So a common example of a psychotic disorder would be like schizophrenia. So this has been a big focus of my research. So there's me. So we start at the clinic. Here's our clinic. What I was interested in doing when we first started our behavioral program is really understanding who our patients were so that I could get an idea of how well the literature reflects them, because I had the sense that it didn't. So in 2004, we started our behavioral program, and because I was kind of like the researcher in the group, I said, let's track our patients in terms of their characteristics, because we do these interviews and intake interviews, and we collect all this information, and I thought we should really be really structured in how we collect this information so that we understand who we're treating, and then we can look into the research and find the best ways to treat them. So the first 131 patients, I had recorded data on things like binge eating disorder, depression, and attention deficit disorder. And here's what we found in terms of those comorbidities. So in our population, about a third meet criteria for binge eating disorder. And this is a disorder where people will have episodes of binging a few times a week where they're eating an unusually large amount of food. So it wouldn't be like going out to dinner and just overeating. It's usually something that's done privately. It has a sense where the person feels very out of control when it's happening, and they would eat quite a large amount of food that could be, upwards of 4,000 calories in a short period of time. So a third of our patients had that pattern. Another third, and some of these numbers are actually overlapping, so came up positive for clinical depression, and 30% actually came up positive on a screener for ADHD. And 60% of our population has one or more of those disorders. So that's over half of our clinical sample is carrying some sort of psychological disorder. Now, we did not screen for all psychological disorders, so it could be the case that an even larger percent of our sample has a psychological issue. So when we first started the program, the first question we ask ourselves is, what intervention are we going to use? We want to have a behavioral intervention that we know is effective. And so what are we going to use? And we went into the literature to find out, is there an effective weight loss treatment program for people that are like our patients? And so to really be embracing evidence-based practice, it has kind of these three bubbles where you want to think about what is the best research evidence. And that's where we go to the library, we visit you guys and say, how do we do a search? And we also want to understand our patient population too. What do the patients want? And then we have to think about our expertise. So we can't do a treatment we don't know how to do or don't have the expertise to do, or we need to learn it. And so that's evidence-based medicine, is to take kind of those three pieces and make decisions about what's the best way to treat this patient. And so that's what we did. And what we came up with in terms of the state-of-the-art program that we could find in the evidence was a program called the Diabetes Prevention Program, Lifestyle Intervention. Have any of you heard of the Diabetes Prevention Program? So this is a really big study that was several years ago. That was the first study to ever show that if you have people go through a behavioral program and make lifestyle changes, it can actually have a bigger impact on their risk for diabetes than if you give them medication. And they use metformin as their medication. And in the trial, they targeted people who were pre-diabetic, which means they were sort of on that doorstep of diabetes. And so they gave them an intervention that lasted about 1 year's time. And, so they randomized people to that or metformin or placebo. And the goal of the intervention was that people would lose 7% of their weight, exercise, get up to 150 minutes per week of moderate intensity activity, behavioral modification, so kind of the standard stuff that we usually do. It's an intensive program where people are coming in every week or every other week to get counseling on these behavioral changes. And so the findings of the study were that diabetes incidence was actually 58% lower in the lifestyle intervention group at 2 years compared to placebo, and 39% lower in the lifestyle intervention versus metformin. And at the time, this was one of the very few studies that I've ever heard of that actually got stopped by NIH early because they found what they were looking for. They had an effect sooner than they anticipated. That was larger than they anticipated, sooner than they anticipated. And so they actually stopped recruitment for the study. Usually if NIH stops recruitment for your study, it's because of harm, not because you found something early. And so it's just a very big landmark study because finally, we have evidence that behavior change works, and not in a small way. It was a big effect, so that was very exciting. And in fact, they've followed these patients out 10 years now and have found that the effect has sustained. And there were 2 other studies, one in China and one in Finland, that found very similar findings. And I forget if it's Finland or China, went out to 20 years, and they continue to find a diabetes prevention effect for this type of lifestyle intervention. So as we read that in the literature, we thought, wow, that is the program that we want in our clinic. That sounds great. So then we look at the samples that are used in the study, the diabetes prevention study. So we're all excited. We're like, this is great for us. And the challenge was, the disconnect was that, again, back to the psychological comorbidity issue, only 10% of their sample had even mild depressive symptoms or greater. So they had really low levels of depression in their sample. And that's not even diagnosable depression. That's just people who their symptoms were at least mild but not necessarily diagnosed. Only 14% had any signs of binge eating disorder, so let alone a full-blown binge eating disorder. And you remember what our clinic looked like. So we're like, ooh, okay, so these people are little, they have fewer comorbidities for sure. And when you look at their very long list of inclusion and exclusion criteria, you could see that there are different things that would probably exclude people who have the kind of challenges that a lot of our patients had. And I'm not criticizing the diabetes prevention program for doing that, because their question really was, if we can get people to do this, will it work? It wasn't really, they weren't really focusing on a very generalizable necessarily population. It was just more of an efficacy trial that's just trying to find out, under the best conditions, will this work? And then the next step is, under the not so great conditions, will this work? And there actually have been some studies that are doing, and that's called effectiveness trial. And there are some studies that are looking into those questions too. So the challenge here is that it's a very highly motivated sample that they use that don't have the same challenges as our patients, but we didn't really have an alternative, so we figured we'd just go for it anyway. And we wondered, can we achieve these type of outcomes in our patient population who we can't impose inclusion and exclusion criteria on? We can't send people away and be like, sorry, you scored over a 15 on the back depression inventory. We can't have you. So to kind of give you an idea of outcomes, in the DPP, again, the weight loss goal was 7%. And so for someone who weighs 200 pounds, that would be like a 14-pound weight loss. And it very much is a philosophy that you really only need to lose kind of a modest amount of weight in order to impact your health. And they certainly proved that to be true. So 49% of their sample met or exceeded that weight loss goal. And it's not that the other 51% didn't lose weight, they just probably lost a little bit less. And I'm sure there were some people, but didn't lose much weight. So in our real-world sample, after our first 160 or so patients, here's what our outcomes were in terms of the percent of people that met that goal. And I broke it down into our little subgroups that we have. So starting with all patients, we had 31% meeting that goal. So we're like, all right, so we're a little bit under, we're definitely under the DPP. So then we looked at, how about those patients with the binge eating disorder? And then we saw our numbers falling to 16%. Only 16% met that goal. And then with depression, it was the same, 16%. Now, if they had both depression and binge eating disorder, it was about 14%. The people who screened positive for ADHD were at about 20% met the 7% weight loss goal. And then those who had ADHD and binge eating disorder, none of them actually met the weight loss goal. Now, if you were to set aside all the people who have those issues and just look at those who don't, our success rate was 44%, which is getting a little bit closer to the DPP. So what we kind of concluded from that was, for the people who don't have comorbidities, psychological comorbidities, we can come pretty close to replicating what the DPP found, but we're not able to do that in people who do have those comorbidities, unfortunately. So now putting my clinical hat back on, I'm thinking, so what do I do about that? 60% of our patients have a psychological disorder, and a very low success rate in our program. And our program's still ongoing. And so what do we do when people are coming in with those disorders when we know that this is their success rate? You know, I've got someone coming in with depression, and I know only 16% of people like them are going to reach the goal and you know, benefit in the full way. So that was kind of our clinical challenge, is what do we do with those patients? In like a one-size-fits-all treatment approach may not be best. I mean, I think that's what that data kind of told us. Should we be sending them into the treatment? This type of treatment is not covered by your insurance company, so you're paying for it out of your pocket. In our program, which I promise you profits none at all, costs $800 a patient. So when I have someone coming in with clinical depression, they have a body mass index of 40, and they're really dying to lose weight, and I know what the people before them have accomplished in terms of success rates, and they want to put down $800 to be in the program, it does kind of put you in this clinical bind of, I want to help this person. I don't want to just send them through blindly knowing that they may not do very well. And what are the implications of treatment failure on somebody who has depression, put down $800 into a program, and failed? That's probably not good for your depression. I don't think that would be good for anybody's depression. And it's not that not losing 7% is a failure, because you know people may lose a little bit less than that, but it's still something to think about. So what's a clinician to do? So we have a few different options. So we can refer them to have their psych disorder treated. And one challenge with that, so when people come in, so you will say, oh, you know, we know, say you have depression, we'll refer you to outpatient psychiatry so you can get some care there, either some medication or some behavioral therapy. And often it's the case that the patient will say, I'm not here for my depression. I'm here to lose weight, and that's why I'm depressed, and that's why I'm not in outpatient psychiatry. I came here. And so you have to think about patient preference there too. And people may not want to go get treatment for their depression when what they're really concerned about is the fact that their PCP sent them to get their weight dealt with. Another approach would be to do both at once. There's not a lot of research on whether that's helpful, because now you're stacking treatments on top of each other. So if you have binge eating disorder, depression, and you want to lose weight, I can send you to 3 different treatment programs. Like that becomes a lot for people to deal with. We don't see, there's a few studies on binge eating around doing multiple treatments, and the findings have been kind of mixed. There was one trial on depression and obesity, and they did not find an effect of their intervention, which what they did was they blended a depression treatment with an obesity treatment. So you would come to the weight loss counseling visits, and they just sort of set aside some time to talk about depression. And that didn't actually work in terms of improving outcomes on weight at all. So back to the lab. I'm putting my research hat back on now. I thought, I think I would like to do a trial on this question and see if we can figure out how to best treat with people who have this comorbidity, obesity and depression. And so our thought was we want to increase those success rates from 16%. So how are we going to go about doing that? And one of the issues that came to our mind was treatment timing. And the one study that was done, they did do the treatments both at one time, and it didn't work. So we don't want to go down that road again. And one of the reasons why maybe that didn't work is because what we find is depression is a barrier to weight loss. When people come in depressed, depression is about kind of, not having the energy and motivation to do a lot more things than you're doing. And so our thought was maybe we need to treat depression first before we even send people through a weight loss program. The challenge to that approach is that, again, it may not be the patient's priority. They might be like, why are we talking about depression? I'm here to lose weight. But we thought, you know what? We're going to try that approach anyway and try to convince people why that might be important for them to think about doing. So this is a trial we called the Be Active study. And it's a randomized trial where we recruited women, 154, who met criteria for major depression and also had obesity. So their body mass index could be between 30 and 40. And our hypothesis was that if we treat depression prior to a weight loss attempt, we'll be able to get more weight loss relative to an intervention where we have no depression treatment. So we had kind of a 6-month period of intervention, and we sacrificed some of that time up front just focusing on depression, and then had people go into a weight loss intervention. Whereas in the comparison group, they spent the entire 6 months on the weight loss intervention. And so we wondered if that would be a good approach. The treatment that we use for depression is behavioral. I'm a psychologist. I do not prescribe medication. And I have a strong interest and expertise in a behavior therapy called behavioral activation. And this approach I liked for this population because it seemed very complementary to what we do for weight loss, and that it really focuses on activity and how people are spending their time. And the idea is that depression is about behavior. Depression is characterized by certain behaviors, and if we can get people to change their behaviors and doing things that are kind of non-depressed or healthier behaviors, their mood will improve. And so we try to understand what sort of activities people could be engaging in that they feel like would be very linked to their values and what they want in life, and try to come up with a structured way to get them engaging in those behaviors more frequently and engaging in less frequently in depressed behaviors. And so we have this systematic process to facilitating that. And it's a pretty effective therapy for depression that's been used in other types of samples with comorbidity. So we thought this could be a nice match for ours. It's also very brief, so you can produce some really good outcomes for people in a short period of time. And then we thought, well, that's good too, because we don't want, 2 really long interventions, because we only have a 6-month intervention period. So I can't put in a 24-week depression therapy, or I'm not going to have any time left to do the lifestyle intervention. But we know that we could do behavioral activation in 10 weeks. So we're like, that leaves us with 14 weeks at least to focus on weight if we have 6 months. I'm going to skip over that for now. Okay, so here's our sample, an average age of about 46 years old, so middle-aged women. So it's a really common demographic for weight loss studies that we found. 71% Caucasian. Of course, they all had depression, and they were all about the moderate severity range of depression. When people came in with very severe depression, we did exclude them only because we were randomizing people to one condition that actually didn't have any depression treatment. And so we felt like that might not be ethical to randomize people with very severe depression to something that is not specifically targeting the depression. So our outcome measures, we use the Beck Depression Inventory, which is been around for decades, a common measure for depression, and of course weight. So here's our intervention timeline. I was kind of describing it earlier. So we had 6 months, which is very common in an obesity trial, where you spend about 6 months doing the most intensive phase of the intervention, and then after that you might have some infrequent visits, but kind of your bread and butter is what goes on in that 6-month period. So in the behavioral activation group, we spent 10 weeks in the behavioral activation. At about week 8 is when we started that lifestyle intervention. And then in the other condition, they started that lifestyle intervention right away, and they had some what we call attention control visits. These were visits where they met with somebody individually to talk about something that had nothing to do with weight or depression. It was just health education. To match the fact that the BA condition had those extra visits. So both conditions actually had the same amount of visits. Give you an idea of that. Okay. So in terms of, I'll just get right to the results of our study. In terms of the results, again, depression was one of our outcomes. And what we found was that in the BA group, we did have a significant advantage in terms of depression remission. So 61% of the sample actually achieved remission compared to 39% of the sample in the other condition. The 39% is actually really interesting because we did not directly address depression in that condition. We just did a weight loss intervention. And that's a higher rate of remission than you would expect, like in a control condition or in a placebo condition. So there actually was an intervention effect in both conditions. They both significantly changed. The BA did better, but we definitely noted that we weren't expecting people to do quite that well in the other condition. So we thought that's interesting. In terms of weight change, we did not see significant differences between groups. Even though you can see the standard condition may have lost a little bit more, it didn't. That wasn't statistically significant, and it's not clinically significant either. So even though the BA condition did better on their depression, it didn't seem to translate to more weight loss. And then we wondered about our findings related, again, back to that diabetes prevention program, their outcomes. So this is that 7% goal again. So you can see the diabetes prevention program, again, they're at the 49%, hit that 7% weight loss goal. If you just pull out women, because our sample was only women, if you pull out women in the DPP, they actually lost a little bit less. It was more like 34%. In general, women tend to lose less weight than men. Very unfair physiological reality. So we didn't want to compare our female sample to the whole DPP. That's why we pulled the women out of the DPP. And our sample of depressed people was about 22% overall hit that weight loss goal. So we actually overall did better than we do in the weight center, because remember that was 12% with people with depression. Was it 12 or 14? I forget. But this was obviously a little bit higher, and this was both of our groups combined. We still have not been able to get people with depression to perform like we're seeing in the trials of people who don't have depression. So our conclusion was that both conditions actually significantly improved depression. Obviously, the behavioral therapy condition did that a little bit better, which is good news, and certainly makes the case for adding the behavioral therapy. But it didn't improve weight loss outcomes. And so I'm still kind of puzzling over how do we get that part to move a little bit more. We really want the weight loss outcomes to move a little bit more. But because they didn't, we started to think about, well, maybe depression isn't as tied to weight as we thought. Because we improved depression, we didn't improve weight as much as we wanted. But I don't think that that's the case. So we were looking at the data in some different ways. And so what we wanted to do was look at people who did really well in terms of improving on their depression compared to people who didn't. Because even though we had these higher remission rates, not everybody remitted. And what we found was that if you look at people who remitted from their depression, which was 63% of the sample, which is great, their average weight loss, which was approaching 5%, was much better than people who did not remit from depression, who almost lost no weight at all, and that was 37% of our sample. So it seems like there's a core set of people in this population that might have a very resistant form of depression, and they're not going to lose weight at all. And then there's another set of the sample that actually their depression is pretty responsive to treatment, and they lose weight okay. They do fine. So now we're trying to think about, so who are those people who got quite a bit of intervention and still didn't manage to lose any weight or make much progress on their depression? And for those of you who know anything about depression, there are forms of depression that are called treatment resistant. These are people who've tried many different types of treatment for their depression, and it just doesn't seem to improve. So they might try 2 or 3 different medications, they might be in psychotherapy, and nothing seems to help. And so we may have, some subset of those people in our sample, wouldn't be surprising. And it's just, another clinical challenge for us to think about. Let's see. Another thing that we thought about was, in order to squeak the behavioral therapy in there, we had to kind of sacrifice some time spent on weight loss. So the weight loss goal of the program was 7%, and we asked people to, from a week-to-week basis, focus on 1 to 2 pounds a week of weight loss. So the people in the standard condition who didn't get behavior therapy, they started doing that on day 1, shooting for 1 to 2 pounds a week. Whereas in our BA condition, they didn't begin to think about that until about week 8. And so it may be the case that, so if I had to do it all over again, I might give the BA condition just as much calendar time to be thinking about their weight as the other group, because that may have actually limited their ability to lose more weight because they just got less time to work on it. That being said, they lost the same amount of weight, so even though we sacrificed that time, it didn't hinder them compared to if we hadn't, but maybe they could have done even better if we spent more time with them. And so this is a research design issue, is when you're working with kind of multiple interventions and populations that have comorbidities, how do you think about designing the study so that the timing of interventions is such that the comparison makes the most sense, which is actually pretty challenging to do. So that's another thing that we thought about, might explain our findings, or lack of ability to see that weight loss effect. So what we thought is depression is a barrier for some people, but not all people. 40% of our weight loss only condition remitted from depression just by doing that intervention. And that may be because they were meeting in groups, they were getting support for each other, they were starting to exercise. Like, all of that can actually have a good antidepressant effect too. But the challenge is not everyone with depression even needs specific treatment for it. So those 40% of people probably, they didn't need the BA, and so they were fine without it. But then it seemed like there are other people who probably do. So one thing that we're thinking about a lot right now is, how do we identify who's going to do poorly in treatment? So that, and what's the earliest point in treatment where we can identify that? Because I want to know who's going to fail. I want a crystal ball, like on day 1, and so I know who's going to fail. And I can't just say someone who's depressed is going to fail, because I know that's not the case. But there are some people who are depressed who will. And so that's something that we're thinking about now, is how can we predict who's going to fail and who's going to succeed? And so we're doing some interesting analyses where what we've done is we look at how people do week to week in terms of that 1 to 2 pound weight loss goal. And we try to figure out what is the first week of, like the first point during the treatment where people who stop meeting the goal are highly likely to fail at the end. And what we found was that at week 3, if you look at how people are doing at week 3, so 54% of those who are on target with their weight loss goal 3 weeks in, so they only had 3 weeks to think about it, stayed on target through 6 months. But among those who are not on target, only 27% of them met the treatment goal at 6 months. So now we have a little bit more information about who's going to fail. So I know at week 3, whoever's not on target has a very low rate, a much lower rate of being successful at the end of the program. So that tells me at week 3 who I need to be thinking about doing something different for. And then we did another analysis where we found, if you check again, because only 54% of those on target at week 3 stayed on target through the rest of the program. So that means 46% didn't. So that's not the best prediction in the world. So we looked again, we did some other analyses and found out if you check again at week 6, 71% of those on target will meet the weight loss goal, but only 31% of those who are not on target at week 6 will be successful by the end of treatment. So we have these little, peaks into how people are doing early in treatment that can tell us who to pull aside to do more for. And so that's kind of the direction we're going right now. And they call that stepped care, where you kind of send people through a treatment, see how they do, and very early on, people who aren't doing well, you pull them aside and give them additional treatment. So we wrote a grant for this approach where instead of randomizing people to the behavior therapy or not, we randomize them to the step care approach where we monitor every week how they're doing, and if they aren't successful at week 3 and then aren't successful at week 6, we roll them into the behavior therapy program and see, if that improves their outcomes. It's also more cost effective because people who don't need it, who are doing well without it, don't get it. Instead of just giving it to everybody who's depressed, because we learn that depression doesn't always equal depression. It's not always the same. Okay. So back to the clinic. After we, finished our trial and we're trying to think, what did we learn from this? And how's this going to affect what we're doing in the clinic and the people who are coming in with depression? Well, what it tells me from a clinical perspective is that depression will improve during a weight loss attempt for some people, and those people are probably going to actually lose weight and do fine. And we've started to do some early monitoring of progress now in the weight center and looking at that week 3 point and thinking of, we don't have a behavior therapy program, but we're stepping up our weight loss efforts at that point, offering them things like liquid meal replacements, which there's a lot of evidence that can improve a weight loss attempt, maybe doing some counseling on the side with them, but giving them a little bit something more instead of just sort of knowing they're going to fail and just letting that happen. So that's kind of how it's affected our clinical decisions in the weight center. So in terms of overall lessons learned, we really do need to think about considering the role of any sort of co-occurring conditions when translating research to practice, because we know that patients don't come in with just one condition, and that could be even just medical condition or psych condition. Nobody comes in with one problem. It's usually there's kind of a constellation of things. It's not so neat and tidy as clinical trials can sometimes be. Another lesson learned, and this is something that I believe in so intensely, is that the patient is the richest source of research ideas. We've got at UMass, we've got the medical school, and then we have the medical center, and there's like a line that basically splits us. But that needs to kind of be a very blurry line and flow, back and forth. I think most of my research ideas have come from my interactions with patients. And I think that's why they influence my patient care. And so I find that kind of iterative back and forth process to be really exciting. Because then I know, at least what I'm studying is going to be useful, for our setting at the very least, and any other setting that might be like it. And then the data is the richest source for clinical decisions. So especially if you're using this process where your research is kind of emanating from patient care, then that data is going to be more informative for clinical decisions. So that's basically like one story of how a clinical trial idea came together and then sort of circled back into affecting clinical practice. And there are many other examples of that, but I just kind of wanted to walk you through that process and show you kind of how some of that is done. Do you have any questions about that, or? Here's me. In terms of weight loss, I write some blogs. This is one of my blogs. It's called FU Diet, so you can find me on there, where I talk a lot about the behavioral science of obesity. And it also reflects my attitude about diets, which is not positive, because I think losing weight is about healthy lifestyle, changing your life, not following a structured diet plan per se. I'm also on Twitter. along with Mando Sally, who's on Twitter. So any questions? I mean, either about the content or the process or anything like that?
Yeah, I was wondering if you controlled for variables like income level and work and disability things.
Can you repeat the question, please?
Sure. The question was, did we control for variables like income level, disability, employment? Yeah, we did collect that data, and when we found differences between groups at baseline, we would control for those things. I don't think that we found differences between our groups on those factors, so I don't know that we needed to control for them for that reason, but we definitely looked at those kind of socio-demographic factors for sure.
I'm wondering, I'm curious whether the intervention of behavior change, treating depression first,
Uh-huh.
has long-term effect. Are you planning to do a follow-up study because two groups may have lost the same weight,
Yeah.
but one group may, for example, who were treated depression, may have maintained
Uh-huh.
weight loss in the long run.
Right. So we did look out to 2 years. The study was funded for up to 2 years of follow-up. And our findings kind of held true. They were consistent over the 2 years to where we saw the depression advantage in the BA group that held out for 2 years, which was very nice because that's a pretty long time for maintenance on a depression outcome. But the difference between the two groups on weight loss continued to be non-significant. So, but yeah, that's definitely something that is a good question. Yep.
When you modified your approach and checked at 3 weeks and 6 weeks,
Yeah.
what were your outcomes on that? You didn't address that specifically.
Well, that wasn't a study per se. We were just looking at our data set from the BA study to see if we could predict who's going to fail by their initial progress.
Are you going to take that approach and try it now?
Well, yeah, I wrote a grant, and it got reviewed, and it did not get funded, so I can resubmit it. I haven't seen the reviews yet, so I don't know what problem they had with it. But yeah, I want to do that study, so if anyone has the money to let us do that, that would be great.
Were any of the people who with depression had previous treatment for depression or were on antidepressants?
Yeah.
Can you repeat the question?
Yeah, the question is, did anybody in the study have previous treatment for depression or were they on antidepressants? Yes. About half of our sample were currently on antidepressants, and definitely people had treatment for their depression before. We controlled for their use of antidepressants, and so we just saw it as sort of a controlling factor more than anything else.
Control, so some of them can increase appetite.
Right. So we actually excluded people who were on medications that affected appetite because we didn't want that variability in there. Most antidepressants don't. Some of them do, so we did exclude those. But there are other psychotropic medications that actually have a more intense effect on appetite, and we made sure to exclude for those, as well as any other medications that might influence weight or appetite. Because when people are on those medications, it adds just a whole nother level of complexity in terms of weight loss, because their weight might actually be going up over time, and so it would be difficult to show weight loss in a group that are on those types of medications. So we did exclude for that, so that we could just zero in on the effect of the depression rather than have that variability around the medication stuff. So, but in terms of medication, antidepressants that don't affect appetite, we still saw 50% of our sample taking those medications. But also think about, they were on those medications and still met criteria for depression, so they were being undertreated, that's for sure. But we left that part alone. We were not going to tell them, you should change your medication, because it may be the case that they're just not being responsive to it, or they need something more. And so, the behavior therapy, could have been the helpful thing for someone who's not responding well to a medication. Yep.
I have two unrelated questions. The first one is, did you look at the weight loss from the amount of time they started the actual behavioral therapy. So, in other words, exclude the depression therapy time and
Yeah.
match them up week to week with that and see how they did.
Yeah.
How they did with that.
Yeah. So the question was, did we look at weight loss kind of taking out that period of time when they were working on their depression? And one thing that we found was people did not lose weight while they were focusing on their depression. So the weight loss that came in the behavioral activation group came after they finished that behavioral activation and started the weight loss program. And I'm not surprised by that because people don't usually lose weight in a depression counseling program. There's not really anything about that would necessarily cause you to lose weight. So we definitely saw that their weight loss trajectory was delayed. So they started later and then they finished a little bit earlier. And that's why I kicked myself a little bit that we should have extended their weight loss therapy to match it calendar-wise. They got the same number of visits, but they spent more time on their weight in the comparison group. And so that may be why they were so equal. So it may have sort of undermined the BA condition from doing better. But that would have caused some design issues too, because then you have one group getting more like longer treatment than the other. So we kind of had to make the call either way. And our hope was by improving depression so much, maybe they wouldn't need as much weight loss counseling. They wouldn't need to spend as much time on weight loss counseling, because we figured that people who are just focusing on weight loss, their depression might be getting in the way so much that they were already at a disadvantage. So it'd be interesting to try it the other way to see if it worked better.
Could you say a bit more about what's special about the behavioral activation?
So the question is, so tell us more about the behavioral activation. So behavioral activation, like I was saying before, it's an approach to depression that's very much focused on behavior. There are other forms of psychotherapies for depression that focus a little bit more on thoughts, like a cognitive therapy, and then there's cognitive behavioral therapy, which takes those and puts those together. But there was a study several years ago that found you can dismantle cognitive behavioral therapy into its pieces, and each piece works just as well as the package, but the pieces are shorter and smaller, and so could be more efficient in certain types of situations. And that's why we went with the behavioral activation, because we could do something shorter than a full-blown CBT. What I like about behavioral activation, even compared to CBT, is that you spend more time on behavioral patterns. So one thing that we do right off the bat is we have them start journaling how they're spending their time in a really structured way. So literally give people these journal pages that have hour by hour and have them tell us how they're spending their time. And so they bring those in and we look at them to see if we can identify their depressed patterns, and they also rate their mood throughout the day. So then you can sort of see what activities are associated with negative moods and what activities are associated with positive moods. Because it's the case that even with people with depression, even though they're depressed, there are things that they do where they feel a little better. And so we want to kind of drill down and understand on a very granular level, what is it on a day, like an hour by hour basis that you're doing, and how does that map onto your mood? So we have them do that for a while. And then we talk with them about what they want in their life or what they value in their life. And we have them think about that in terms of the different areas of your life. So think about your relationships. So we'll ask somebody, what do you value in your life about your relationships? So let's say someone's a mom, they might say, what I value about being a mom, like what's important to me about being a mom is that I have quality time with my child. So we say, okay, that's great, that's great. Then we might say, so with your work, what do you value about work? Like what are you striving for, big picture wise? And they might say, what I'd really like to do is advance in my career. I'd like to get to the next level. So we say, that's great, that's great. And so then what we do is we take those two values and we break them into activities. So we'd say, what is a few small things that you could be doing, let's say, to spend more quality time with your child? Like what would that look like on a Tuesday? And so they might say, well, like for example, we would play cards, or we would throw the softball around or something like that. So we have them break their values into activities. And so we get these lists of activities once they've done that process. And we do all the different areas of life: work, education, recreation, spirituality. And we get this list of activities. And then as they're doing that journaling, we have them start scheduling in some of those activities. Because we know those activities are things that are connected to things they really care about. And what happens with depression is that a lot of our time can end up getting spent not on things we don't care about necessarily, but things that aren't very well connected to our values. So, like, for example, someone with depression might spend a lot of time watching TV at night. They get home from work, I'm so exhausted, watch 4 hours of TV. That time isn't well connected to their values. So that's kind of what we're trying to break up, is those patterns of time where it doesn't feel very connected to where you really want to be in your life. So we have them schedule those, we call them valued activities, and get more and more of those into their days. And what we find is that when people are doing things that move them closer to where they want to be in life, in the different areas of their life, they do feel better. And you'll see that their mood ratings go up. They'll be like, I'm so glad that I am spending more time with my daughter. I always felt so guilty because we didn't spend much time together. Now I've scheduled these little activities. Or I'm finally looking into what exams I would need to take in order to get that next certification to advance in my career. So we kind of, in these very tiny, small step ways, get people kind of moving towards where they want to be in their life by breaking it down into like little activities. And it's an amazing process because it works so well. And as people are doing more and more of those activities, their mood definitely starts to increase and they feel better. So by the end of the 10 weeks, we saw that those back depression inventory scores had definitely improved a lot. And so we thought, okay, so maybe now they're feeling a little bit more equipped to kind of start thinking about putting their weight loss stuff on the radar as other aspects of their life are kind of falling better into place. Because often in weight loss counseling, we can't really focus on all that stuff. And you can see how it's a problem. Like someone will come in and they're like, the reason why I can't exercise is because, and they're doing all these other things and they have obligations and spend time doing things they don't want to do. And it's a little bit harder to kind of get at some of those bigger picture issues in the context of the weight loss counseling. So the BA kind of gives us an opportunity to really focus on broader life issues. Other questions?
I actually think we should.
Where should you go? Okay.
Yeah, you'll have to. You can find her.
So thank you.
Thank you.